The last learning objective is explain the toxicodynamics of vancomycin based on serum, trough, and AUC. There are a lot of studies that have looked at the correlation between vancomycin trough and toxicity, specifically nephrotoxicity. So here on the horizontal axis, we're looking at different levels of trough. So less than 10, trough of 10 to 15, trough of 15 to 20, and trough greater than 20. And then on the vertical axis, we're looking at the rates of nephrotoxicity. So you can see that basically not much difference if the trough is less than 10 or 10 to 15. However, when the trough starts to go above 15, you start to see increased the risk of nephrotoxicity, which is highest when the level is greater than 20. So because the risk is greatest above 20, you should never have a trough of greater than 20 unless the patient is on continuous infusion. These troughs are only pertinent to intermittent dosing, so these numbers don't apply to continuous infusion. And of course, even 15 to 20 is still more nephrotoxic than 10 to 15, so more reason to avoid targeting 15 to 20. Now, this is a systematic review and meta-analysis from multiple studies, and they're looking again at the same groups. Trough less than 10, trough 10 to 15, 15 to 20, and greater than 20. And in the meta-analysis, specifically, they compared trough of 15 or higher versus anything that's less than 15 to see if it makes a difference. And so these are all the different studies that they have added to this meta-analysis. And then the sum of all of these studies shows that there is a significant increase in odds of nephrotoxicity with trough of greater than 15 or greater than or equal to 15 compared to trough of less than 15. So, more and more evidence suggests that trough of 15 or higher is actually nephrotoxic. And there are many risk factors for nephrotoxicity. There are a lot of studies done, and they found that if the total vancomycin daily dose is more than 4 grams or 4,000 milligrams, the patients are more likely to have nephrotoxicity. If vancomycin trough is greater than 15, which I just showed you, also if the vancomycin AUC is greater than 700, that's also nephrotoxic, and that's why the new guidelines are targeting an AUC of 400 to 600 because they don't want you to reach 700. Also, if the therapy exceeds 6 days, so if someone is on vancomycin for just a few days for empirically and then you discontinue it, they're less likely to have nephrotoxicities. When patients have longer periods of time, that they're more likely to have nephrotoxicity. Also, concurrent use of other nephrotoxic agents such as aminoglycosides and Piperacillin-tazobactam, and also some antifungals like amphotericin B. They can be, along with, sometimes patients are on NSAIDs, for example, that can cause, that can be nephrotoxic. Patients who have pre-existing renal disease, and that's defined as serum creatinine at baseline of 1.7 or higher, or if their creatine kinase was less than 86.6. So these are risk factors. Obesity was also risk factor, and that's defined as a total body weight of 101. The way they came up with these numbers, basically they've done logistic regression, and that's how they have come up with these numbers. They found statistically significant correlation between these and nephrotoxicity. The next one is hypotensive episode. So for example, someone who actually developed shock as a result of the infection, they were more likely to develop nephrotoxicity. That could be in part due to shock results in hypoperfusion of the kidneys. So if the kidneys are not getting perfused adequately, they're more likely to see damage. And lastly, increasing severity of illness. So patients who are more ill are more likely to develop nephrotoxicity. So the longer someone is in the ICU, the higher the risk of developing nephrotoxicity. And lastly, since pretty much the old guidelines were targeting 15 to 20 for more severe infections, and I just showed you that 15 to 20 is more nephrotoxic than 10 to 15. They want to see, well, since we're targeting 15 to 20 for more severe infections, is 15 to 20 even more likely to achieve the AUC to MIC of 400 compared to a trough of 10 to 15. So they did this study and they actually found that more, patients who had a trough of 15 to 20, they were not more likely to have an AUC to MIC of 400. So even though their trough was higher, they were not any more likely to have that AUC to MIC of target. So the new guidelines actually do not recommend a trough of 15 to 20 anymore. More and more evidence shows that 15 to 20 is nephrotoxic, and also 15 and 20 is not likely to result in better efficacy. So for most patients, 10 to 15 is sufficient, and really we should be targeting AUC to MIC in our patients for efficacy. This concludes this presentation.